Hello, my name is Chantel Pankratz, and today we will be discussing breastfeeding in regards to the challenge of a mother with inverted nipples taking care of a preterm infant. This is for the BCIT Breastfeeding Theory course. The outline of this discussion will be a look at the situated clinical decision-making framework, which is comprised of a knowledge base, in this case of preterm infants and inverted nipples, and then cues, judgment, decisions, evaluations, and summary. The situated clinical decision-making framework helps guide our care by letting us assess the challenge and provides us with a course of action and an evaluation tool of how this course of action has been successful. It is comprised of the knowledge base, and from this knowledge base we know to look for cues, and these are signs and symptoms. Then we have judgment, in which we will look at 3 priority problems, decisions or treatment and management of the challenge, and then evaluation, effectiveness of the treatment. Knowledge. A preterm infant is any infant born before 37 weeks, and there are 3 different variations of this, and each provide their own problem. The preterm infant is much more likely to be in the NICU, which will prevent a supportive and effective breastfeeding experience. As well, preterm infants have various physiological differences from a full-term baby that will prevent or may prove challenging for effective breastfeeding, such as immature immune and digestive systems, insufficient energy stores, and these 2 are significant to note, as because of these, breast milk is especially important, as this will help boost the immune system and ensure that hypoglycemia does not occur. Breastfeeding challenges can be due to physiological differences of a preterm baby, such as a smaller mouth that has difficulty latching on the nipple, an uncoordinated suck, difficulty latching, or low energy and fatigue. Inverted nipples. This is when the nipple is, instead of protruding from the areola, is retracted. And this can provide some difficulties in the baby latching onto the breast. Although it is important to note that some mothers do not have difficulties breastfeeding their children, and it is absolutely possible to breastfeed with inverted nipples. This may be one or both breasts with inverted nipples, and it could be congenital, as the mother was born with it, or acquired due to pregnancy or breast trauma, and this can provide some difficulty latching with the baby. Cues, or signs and symptoms. There are many indications that the mother is experiencing challenges when breastfeeding. There may be sore, tender nipples that are cracked or bleeding or scabbed over. This is usually indicative of a poor latch from the baby. And misshapen nipple, such as it appears like a tube of lipstick instead of perfectly round. There could be engorgement, which means the baby is not effectively removing the milk being produced by the mother, which can cause uncomfortableness for the mother. Inverted nipples despite stimulation, no expressible colostrum or milk, and feeling overwhelmed or unconfident with a breastfeeding challenge. Signs and symptoms of breastfeeding difficulty with a preterm infant is weight loss equal to or over 10% of birth weight, low urine or stool output, fatigue, or dry mucous membranes. These indicate that the baby is not receiving adequate nutrition. Poor latch or poor suck are also signs that the baby is not feeding effectively. Judgment. This is where we think on what factors are creating difficulties for effective breastfeeding, as indicated by our previous assessments. And this is where we decide what the top priorities are for addressing these challenges. The top 3 priorities for any breastfeeding challenge are to feed the infant, move the milk, and support the dyad. Decisions. These are the interventions that we will take to address the challenge. For a preterm infant, it is important to assist with the latch. One technique is to have the mother hold the breast as if she is holding a sandwich. This compresses the breast and allows more area for the baby to latch onto. Skin to skin is always encouraged when breastfeeding, as this helps promote bonding, calms the baby, and facilitates breastfeeding. Expressible colostrum. Even expressing drops of colostrum and rubbing on the nipple can help stimulate the baby and entice them to latch on and feed properly. Stimulating baby if the baby is fatigued, such as gently blowing on the face or gently tickling the feet, can help keep the baby active at the breast. Hand express simultaneously while breastfeeding. Have the mother compress the breast. This will help force milk through the milk ducts and into the baby's mouth to ensure nutrition even if the baby is not effectively suckling. Feed frequently. So although there is a rule often told to mothers that they are to feed every 3 to 4 hours at least, we encourage breastfeeding on demand. And this is easier done when the baby is in a quiet, alert state instead of actively crying. Supplementation. So this can be if the mother has lots of breast milk or colostrum, to express breast milk, or use donor milk or formula if indicated and the baby is losing more milk than intended. And lastly, collaborate with additional healthcare professions. Pediatricians, midwives, and lactation consultants are good sources of expertise here. Interventions for mother. Skin to skin, again, is always encouraged. Ensure the mother has a quiet, comfortable environment in which to breastfeed. Pillows supporting her back. Make sure she brings baby to her instead of breast to baby to ensure maximum comfort for herself. Assist with positioning and latch, such as using a cradle or modified cradle pose, or with mothers with larger breasts, they may find football hold is more comfortable. Protect the nipple. So even expressing colostrum and rubbing on the nipple before latching the baby provides a natural barrier for any rubbing and chafing of the nipple. As well, mothers can get lanolin, a barrier cream to help prevent chafing or irritation of the nipple. Avert nipples just before latching the baby. Some nipples can be averted with some stimulation or rolling out of the nipple. This may not be possible, and if not, there are still ways that we can overcome this challenge. Hand express or pump. We want to discourage any engorgement from happening. So expressing any milk after a feed discourages engorgement and also will provide additional nourishment for the child if needed. Support the mother in whatever manner she needs. She may be feeling overwhelmed and unconfident with handling breastfeeding. However, it's important for us to promote confidence in the mother, celebrate all victories that occur, and support her in all her decisions. Last, again, collaborate with additional healthcare professionals. People such as lactation consultants or the public health nurses that will support her in her home are excellent resources. Evaluation. Have the interventions been successful in addressing the 3 priorities of feeding the baby, moving the milk, and supporting the dyad? The preterm infant. So signs that the interventions we have undergone have been successful include feeding 8 times or more in 24 hours, a healthy weight gain, good urine and stool output, good blood sugars, appears hydrated, good latch and suck, and content after feeds. For the mother, she should feel confident and supporting in her breastfeeding. She is able to position and latch independently, may be able to avert nipples, although if not, that still means breastfeeding can still be possible and comfortable. Her nipples are intact, so no bleeding or chafing. She is comfortable using breastfeeding aids such as nipple shields, if that is required. And she is comfortable supplementing with express donor milk, formula, if needed. Summary. So, as we have seen, our knowledge of preterm Infants and inverted nipples have helped guide us to look for cues, such as poor infant weight gain or nipple uncomfortableness with the mother. We have judged that the three priorities of feed the infant and move the milk and support the dyad are the most important, and due to this, our decisions, our interventions and managements have been put in place to address these issues. We would then evaluate our interventions and see if, as with the previous slide, if we see these cues, then our interventions have been successful.